Hi, it's Matthew Holt. You have reached THCB Gang. It is episode 42. The date is February the 11th, 2021. And thrilled to be back for another hour or so of witty repartee and hopefully some healthcare information and knowledge about policy, the goings-on of the world, and technology thrown in there as well. All right, on the guest lineup today, I have... Man, we're a bit old and male this week, so we'll have to try and correct that for later. But I have Ian Morrison, health futurist at Second Curve. Raj Aggarwal, I guess the youngest male on the team, surgeon these days, senior SVP at Panda Health startup. Kim Bellard, regular THCB contributor. Michael Millenson from Health Quality Advisors, patient safety expert from Chicago. Vince Kuraitis from the wilds of Idaho, consultant and policy analyst, and of course, holding up the non-white chromosome end all by herself today is Grace Cordovano, board certified patient advocate from New Jersey and UCC New York. All right, so we're going to go live, and I'm going to ask the gang what they have been thinking about this week. So I'll start with you, Kim.
Well, the impeachment hearings have been hard to miss, and it's as jarring, this week as it was January 6th. So it's been tough to take.
Ian.
Nothing but positivity.
Right, so we're gonna go
Scotland rugby team beat England at Twickenham 11-6, the first decade. So as a former hooker, I was overjoyed by that. But no,
you have to
more
explain
seriously,
the Americans. That's
I can be problematic.
No, but back in the day when Ian was a hooker, they were all amateurs.
Yes, exactly. They're no.
And Ian, you're far too tall to be a hooker. There's no way you're a hooker. You're far too tall.
Wow, this went downhill really quickly.
Yeah. Sorry about that. No, actually, but on a positive note, just before we came on, I was listening to UCSF Grand Rounds and Monica Gandhi, who's brilliant. She was going on giving a review of variants and vaccines, and I came away from that very, very, very encouraged. Her punchline was try not to worry about the variants. There's probably, I think she said 12 cases in the US of the various strains, but she went systematically through all the vaccines that are approved in the US and are likely to be approved with spectacular efficacy still on preventing severe disease. So, I mean, we're not out of the woods, but it's encouraging. We just got to get more people with vaccination, and particularly vulnerable groups.
Right.
I'm completely buried in just trying to schedule vaccines. I feel like I've become a vaccine appointment hunter. I'm literally trying to share all of these tips, navigating snowstorms and how to hack an appointment, because people living with cancer and who are qualified to and eligible to receive cannot get them. So no surprises here. We knew the rollout was going to be a mess because such is healthcare, but I think people are appalled and really devastated and feel like their lives don't matter, when the reality is that they can't get the care that policies and science say they need.
Yeah, it's I'll just put in my sort of comment for the week, because I've just come off the program that Catalyst, which is the company I co-run with India Sabaya, has been doing on behalf of Robert Johnson Foundation. We got paid by them to help out, sort of do what's called a rapid, sort of kind of like a rapid RFP. And Jacob Ryder's organization, the Alliance for Better Health up in upstate New York, has been working with us. And they've been, Jacob's a very smart guy. He used to run ONC, was at Allscripts for many years. Also had the very first ever healthcare related blog, by the way, even older than the healthcare blog, back in the 90s. Jacob's been working on this with his team for the Albany, New York area, trying to figure out how do you schedule people, how do you message them about it? And we've gone through a whole ton of people who applied with their technologies to show this. And the answer is that the technologies that were paid for, the feds paid for Deloitte and some other stuff, haven't been working. And now the private sector tech companies are trying to figure out what to do, but there's a lot of complexity in both scheduling, also messaging people, because you've got to figure out who the most vulnerable needs it, how to get to them, and then of course tell them that they've got to come back in three weeks or 4 weeks to get the second dose. There's a lot going on, and we are nowhere near ready for that. And you kind of think we should have been prepping for this for the last 6 months, but all right, that was my comment of the week. Michael.
I by having my wife's computer and my computer next to each other at 5:30 and 6 in the morning, I was able to get appointments for both of us. So we both had our first vaccines on Monday. We have appointments at 4 different Walgreens, none of them anywhere close to us, although Cicero, Illinois is beautiful at 9 in the morning. The way the Walgreens is arranged, which this is supposed to be a modern corporation, right? You book appointment 1 for each other. Great, we're at least the same day. You go to book appointment 2 and a Walgreens shows 10 available spots. You pick one, it says not available, and then it cancels your first shot as well as supposedly you go to your second shot at the same site. And therefore, you have to start all over to hope in the time that's elapsed that you can still get a first shot, and then guess again on a time for the second shot. So it took me 6 or 7 tries to have to start over to be able to get a second shot for her, different day. But hey, at least we got it, right? And so the whole thing is just amazing. When we went down, my wife went down to the Walgreens where she got her shot, a different place completely, right, up and back. The pharmacist told her that they have 20 shots a day. So think of a city like Chicago, Chicago area, where not all the Walgreens, maybe, I don't know, 10 or 15 times 20 shots a day. Well, we'll have this licked in no time. So presumably more vaccines will be coming. Meanwhile, in healthcare that's not personal, we're going to solve everything with amendments to the COVID relief bill that will solve the drug pricing problem, Medicaid, ACA expansion, and everything else. And they'll all be amendments and nobody will notice it. And we'll wake up one morning and healthcare reform will be over.
We may talk about that in a bit. So hang on, I want to know, Michael, are you 1A, 1B?
I'm 1B. And because I'm over 65, but you know, if you wait for your county or your health system or anything else to tell you, we feel lucky. There's an article in the Washington Post today about how screwed up things are and people are having their appointments canceled. So we're happy we got appointments. They weren't canceled. And, basically, except for the anxiety and the ridiculously of it all, theoretically it will work.
Who here thought that Michael was over 65? I don't know. I was going to say I didn't realize you were that old. All right, Vince.
Thanks, Matthew.
I never thought you were that old. Like,
if I could hear that or remember that, I'd be angry.
Vince.
If you hear the dog barking, let me know. I'm going to take this a little different direction. You wrote about something, Matthew, a couple of weeks ago, and I'm going to expand on some of the things you wrote. It's probably more of a discussion topic, but I'd like to introduce it because it's really gotten my attention. The topic is around the mushrooming of virtual care and virtual care first companies. We've probably heard of this in terms of telehealth. You wrote about an article that had been a presentation made by Julie Yu, a venture capitalist with Andreessen Horowitz, and she listed a couple dozen of these. My visual metaphor for what's going on here is, you're out in the middle of the ocean and the lava is beginning to bubble up, and we're beginning to see the birth of a whole new island off of the mainstream. And it's initially just lava, but it's going to have plants and life, and my gosh, it's going places. And there's so much talent in just this group. Healthcare incumbents have been very difficult to deal with. The EHR companies, hospitals, the sales cycle. It's a regulatory environment. There's so many things driving this, and in particular, Ian and Michael, at some point, I'd love to hear your thoughts. If I were a hospital or delivery system, I'd be scared spitless by this whole trend because it's hard to compete. And even, Teladoc has labeled themselves as a virtual integrated delivery system without all the capital of, the 24/7 operation and the buildings and the MRIs. Where does all this go? It's fascinating to me. So I'm going to just lay that out there and hope we can begin to talk about it a little bit more later on.
Yeah,
Raj is your man. That's Raj's
Well,
life.
there is demand. There is a new. I just found out this last night. I was on a clubhouse call with a guy from Oshi, which is a virtual GI, Crohn's IBS disease sort of clinic, and they were talking about there's a new merge, there's a new sort of joint venture pressure group lobbyist, whatever new thing from the Society for Digital Medicine and the ATA, American Telemedicine Association, which is called the Virtual First. I don't know. It's something like the Virtual Care First lobby group, but it's not. But it's that kind of thing.
Yeah, there's an organization now.
Yeah. All right. So, Raj,
by the way, Matthew, make sure you send along that referral because I'm due for a colonoscopy. So I'd love to have a virtual one rather than an actual one.
well, you can have a virtual one. I had a virtual one the other day. You do the thing where you poop in the toilet and you scoop it up. It's much easier than having a garden hose shot on the backside.
I agree with Ian. I think we're all.
Hang on, Rabble. We have to wait. We haven't asked Raj. We're like 12 minutes in this. We haven't asked Raj yet what he saw this week. So, Raj.
Yeah.
Oh, gosh. There's so much there, and I'm just going to throw about 15 years ago, we looked at a startup out of China that was doing robotic water-propelled colonoscopy. And you can literally, the plan was you could do it at home. You just put,
Yeah.
It didn't work. So I've been thinking about this question, Matthew, and there's been some extraordinary events over the last week. Somebody won 7 Super Bowls. Is that the most extraordinary event? Is it that somebody's getting impeached for the second time? Is it that there are 58 SPACs in healthcare without a target right now?
57, 23 amigo.
7? Oh, okay. Or is it that, in my new role at Panda Health, I'm a doctor who's turned into a panda, and we have attorneys that turn into kittens as well right now, right? But I actually think the most interesting thing is not around digital health. There was in the news this morning, published in the New England Journal yesterday, about a new obesity drug. And obesity is a pandemic, and we've heard more about it from COVID. And, as you know, I am a bariatric surgeon, and this drug was given to, I think, 2,000 people, and, randomized trial. Rachel Batchram out of University College London, I know her well. She's very highly sought after scientist. And they lost 20%, 30% of the patients in the intervention group lost more than 20% of their body weight, which is remarkable. Most of these drugs do 3 to 5%. I have to say 60% of them had symptoms that such as diarrhea and nausea and bloating from this drug as well. But my take on that is this is really impressive science, and no one's talking about it because we're all focused on, the moment and whatever. So my kind of broader take is, what about all the other science that's happening right now in the world for whether it's on obesity or whether it's on cancer or whatever? It's just not getting any media time at all. And I feel like a wall against, or certainly in terms of the common person of, all we hear about is the science around COVID, rightly so, but what about all the other science that's happening and improving healthcare right now? So that's kind of my rhetorical question, I would say.
Well, I think before we go into the conversation, I'm stunned you've all missed the most important news of the week, which was that yesterday the Wall Street Journal started saying that healthcare to being one word and not two, and frankly,
oh really?
That's the final straw. We knew that Murdoch brought that paper to destroy it, and he's finally done it now.
Oh my goodness!
Sorry, Michael. I quoted out to your Ashish Jha says that's okay, and I was explaining to him that he'd better go back and enjoy his time with the Ron Johnson Senate committee hearings as opposed to the beating he was going to get on Twitter. But I quoted your piece from I think it's 2010.
A2 Rupert Murdoch.
Exactly. All right. Well, those of us who are two-word sticklers here will have to deal with the incursion on our shores and see what we can do about it. But let's start on a couple of things. A couple of things came out of there. There's a lot going on. But let's for a start go to the pandemic bill. Who is prepared to tell me what they think is going to be in the bill regarding? Maybe you touched on this, Michael, or maybe Ian as well, touching ACA extensions and what else is likely to be in the bill that's going through the sausage making now, in the background while we've got the impeachment trial in the foreground.
Ian, why don't you go first, and
Well, I'm not. I'm certainly encyclopedic about this stuff, but what I'd say is that the intent, if you read the Biden kind of position papers in advance, was to use whatever levers they could to, expand coverage and make it more affordable by juicing both the subsidies on the one hand and the level at which, the family glitch problem, to make it more accessible on the exchange subsidy side. My understanding is that there's a 5% 2-year boost to the Medicaid match if you were to do expansion, which may induce some states to go over the line. But I mean, the people are left, the 12 states that are left, are ideologically opposed to it. Free is not cheap enough for many of them. The one exception might be Georgia, given the changes in the Senate and how close Stacey Abrams was to becoming governor. I think that would have been a kind of a no-brainer. But it's not without question. If they do a plebiscite, then I think it opens the door for Medicaid expansion. And if they can get something through, and the only other thing I'd say in terms of coverage would be reversing the neglect of exchange support will have an effect on increasing coverage of both exchanges and Medicaid, even if they don't put money into the bill.
Let me just add a couple of things to that. So they are trying to help make easier to use exchange and the changes that Ian mentioned. They are looking to expand maternal coverage under Medicaid, which has bipartisan support, that would affect all states, so that a mother would not have to be kicked off Medicaid after 60 days in a lot of places due to income. They're trying to throw in a drug pricing bill that would affect Medicaid rebates that they can get to put some pressure on drug pricing. And of course, they've gone to the Supreme Court and reversed the Trump administration's support of the lawsuit against the ACA. It said, never mind, we like the ACA. I will add one thing to the health reform. All the things that we just talked about are sort of small, under the radar things that can have a big impact, right? But they're under the radar. They don't require really a separate vote. So politically, they're easier to do. They don't attract a lot of attention. They're stuck in there, right? Well, everybody's worried about COVID. So there was an article in the Health Affairs blog today by a group of academics that's called 1% Steps to Healthcare Reform. And there's 16 different small things you can do that are actually practical, that could affect significant amount of money in healthcare. And so when we have academics proposing practical things to do, who knows but that real healthcare reform is now on its way.
A big question I have for the group is, who the hell's going to lead CMS? I mean, I'm kind of amazed that hasn't been.
They've got the two names. Mandy Cohen from South
North Carolina,
and then the woman who's at Manat, Rodriguez something, right? Who I forget her last name, but she was also, both of them were senior staff people at CMS beforehand. Yeah. And I heard a talk by Chris Jennings with the Brandeis folks last week, and he basically said they're going to pick someone for CMS who's been there, can immediately, interact with all the other agencies, knows their way around the federal government, and really can get going. The other thing they said essentially is that because their HHS person has not yet been approved, they're kind of keeping some of the other kind of appointments in their pocket for now, because you want to get that going.
Yeah, I know Mandy. Yeah. I know Mandy well. I think she is fantastic.
And this other woman apparently worked under the California guy who's going to become HHS secretary. So
yeah, Sarah.
So the other, just worth pointing out, so what we're trying to do is expand the ACA exchanges, expand the subsidies. There's this proposal to limit total premium as a share of income to, I think, 8% or 8.5%.
Right.
So we'll see what the stuff all comes out of the committee. And that can all be done in the reconciliation. Anybody know, it was in the Biden proposal, could you get Medicare age reduction down to 60 on the reconciliation?
I don't think
that needs 60 votes. Because, I mean, frankly, if you were going to propose anything taking 60 votes, it wasn't worth proposing.
And to be fair, reconciliation in terms of the Senate House bills should be rephrased as, what does Joe Manchin want, right? And so,
right, exactly. Terrifying, but true.
Can we get Medicaid expansion, some other things? Maybe. Can we get drug price kind of stuff? I don't know, right? Minimum wage. So it's really going to come down to, which proposals are bipartisan. Republicans and Democrats love moms, and which, you're not going to get the votes for.
I mean,
my Apple Watch is just cueing me repeatedly. So I don't know. I have to ask somebody if these are tied to any kind of vital signs, but it's just saying breathe, breathe, breathe. This conversation about what's going to be included, what's not included. Matthew and I were in a conversation last night at Clubhouse about, the movement towards value-based care. And I have to say this again. Where is the value and what does this mean for patients? Because what I'm dealing with the patients and families that I'm working with. So, the drug pricing obviously is an important conversation, but financial toxicity, out-of-pocket costs, surprise billing, balance bills that are just crippling. So if you have a chronic condition, a life-altering or life-limiting condition, all these conversations are happening up here somewhere, but nothing is changing at the bottom line and no one's really saving anyone anything. I feel like we're just drilling more financial toxicity. The conversation on Clubhouse was, value to the patient means your outcomes and if you're not hospitalized. I get that, but if you're not hospitalized at an expense of $100,000 that you don't have, what are we really talking about?
Yeah, but Grace, you're in New Jersey, and so we're talking about people that have not expanded Medicaid and things like that. So the people who are really, really at the bottom, who can't even get to someone as knowledgeable and empathetic as you are, this will help some of them. The problem, of course, is from a policy point of view, to get the kind of help that you want for vast numbers of people, you need more votes, and you run into the special interests, and that's unfortunately a reality. So I think you're right. We're helping some of the people at the very bottom, but not the vast majority of people who need it.
And I don't agree about not having expansion. I mean, there's so many critical, and at first I don't even know how this is a debate. What are these people supposed to do? How are we even still talking about this? That's appalling to me. So when we have conversations about healthcare transformation and innovation being so patient-centered, guys, obviously you haven't had a walk through healthcare's park.
Right.
Grace, you had a great tweet about what's the most misunderstood word in the healthcare system, and you said patient.
Absolutely.
Yeah, just to build on Grace's point, I mean, even the surprise bill legislation, which passed in December, 27th, or it was one of the last things to go over the line before Trump got fully engaged in rioting. But But even that doesn't kick in, as I understand it, until January 1, 2022. So,
right.
For Grace's patients, I mean, it's comforting to know that they're going to be somewhat more protected. But they're sick now; they're paying this stuff now.
And even if they take an ambulance ride in 2022, that doesn't count because the ambulance company somehow got that through the lobby. Yeah. But it's okay in an air ambulance; they can't surprise bill you, but a ground ambulance can. So
those bills
if you have a problem, call a helicopter.
And those bills are ridiculously expensive. I had patients during a surge that could not get an ambulance for transport to an essential place of care. And they waited and waited for transport. The medical team approved the air transport, and the bill is between $80,000 and $100,000. That's not covered. Surprise. And some of those patients died on top of it. So imagine you've buried your loved one, you're grieving, and you get this bill, and you did exactly what the care team told you to try to save your loved one. I have no words.
Yeah. And they're all owned by private equity companies.
Absolutely. I mean, and the joke is that they were the worst, the air ambulances, but somehow they didn't have enough clout to get left out of the bill, but the ground ambulances have. And as you say, Ian, it doesn't come in until 2022. So there's so much. I mean, I think the conversation we had last night, Grace, is that we're talking about value-based care and patient-centeredness, but there are so many sort of octopus tentacles coming in to figure out ways to get around it. You had the one. I mean, I was saying that Sarah Cliff from the New York Times is a job for life because all she does is write about this stuff, and she found this one where hospitals weren't accepting insurance from their from people who had insurance because they were trying to from a car crash because they wanted to sue them for the settlement that was going to come because they get paid more than if they accept the insurance. I mean, it goes on and on and on, and every week there's another hospital system somewhere with its fingers in the in the till or creating with putting liens on houses or what have you.
I just want to hop in with my usual optimistic view. Ian, you mentioned private equity. The good part here, optimism, is private equity folks make venture capitalists look like saints.
Yeah.
That's your optimistic view?
that's the optimism, right? He's made the VC guys look better. I mean, so I just want to take it. So, we're kind of getting to that sausage making part of the bill. Do we think there'll be, I mean, collectively, is this it? Is the Biden administration essentially, I mean, it's going to do it's got to deal with COVID, and it's all that vaccination rollout, and Andy Slavitt and Jeff Zients and, doing their thing, and you've got the whole team doing that, and hopefully it'll get better, right? It looks like the numbers are picking up and picking up, going to be about 100 million. Maybe we get the J&J vaccine, which is 60-70% effective and only needs one shot. They may have more manufacturing capacity and maybe easier to make that in other plants than it appears that the DNA one, sorry, the RNA one. Can't remember why science somebody. RNA from Moderna and Pfizer or biotech.
mRNA.
Thank you. mRNA one. The Pfizer and Moderna are putting out. Apparently it's easy to make that one, so maybe it can be made at a bigger mass scale and get to more Americans. Looks like the Russian one bizarrely works, which I think no one actually expected. But the Lancet says, okay, the Lancet said that Andrew Wakefield was true for a while as well. So no. Okay. But I mean, it looks like we're going to that sort of technological war powers act thing has got Defense Production Act has got to happen. But I mean, I guess my other bigger question is, once we're done with this big $1.9 trillion bill, whatever healthcare stuff gets lobbed onto it, along with minimum wage and who knows what else, is that it? Do we think from the Biden administration for sort of healthcare policy? Do you think they can have a chance at coming back and doing anything else? They do have 51 votes in the Senate, after all.
Well, the Medicare option, we've talked about that. I mean, I've been
talked about it.
That's on the, that's coming up. That would be huge.
Yeah, I personally think realistically that if he can get some of the things that we've been talking about in this big bill, I mean, if you read Obama's book, I haven't read the whole book, but I read the healthcare chapter earlier, but he blew his brains out, with the promise of a few Republican senators coming over the line. I think Biden's savvy enough to know that that's probably not going to happen. And I think it's unlikely. I agree completely with Vince. If you could adjust the age on Medicare, that actually has huge knock-on implications, but I'm not holding my breath. I'd almost settle for a well-supported Affordable Care Act in the hands of a democratic, sensible CMS with inducement to the holdout states to do more. Maybe I'm just getting old and cranky and tired, but it seems unlikely given the division in the country that we're going to get much more than that in the short run. But if Biden conquers COVID, both economically and is seen as a hero by the end of the year, then I think you may have political capital to go another round.
I think that after COVID, there's not going to be a lot more healthcare stuff. He's got to pivot very quickly to jobs and whatever that means. It's build America better, whatever it is. He saw what the Republicans did with jobs, and he's got to do the same thing. But he's got to make it look like it's, for the future, clean energy, whatnot, that kind of stuff. But
infrastructure.
Some investment in this.
Right. So he gets this on the 60 votes, and you go to infrastructure, where Republicans and Democrats alike are always in favor of spending money that will benefit their home district. There's a lot of consensus about that. So, and jobs, exactly what Kim said.
I was dismayed at Secretary Pete's confirmation hearings. They asked him about the gas tax, which has not been raised in 25 years. And he had to backtrack on any semblance that it might go up. I mean, these what pays for roads, and we can't even talk about keeping it up even slightly with inflation. It's worse than minimum wage.
I would love to see more investment in science. We've seen what the power of public-private partnership does and what investing in science does. And as someone that comes from academia, one of the reasons I left academia was there just wasn't enough funding. I had an incredible mentor and boss, brilliant gentleman and a doctor, and he couldn't get funding. I mean, that's concerning. How are we going to support women scientists, young scientists who are looking to spearhead research? How are we going to support people of color and those that come from marginalized communities? How are we going to bring in talent if we don't have the funding? A lot of these things could go quicker, and science and research are always cut. I'd love to see more there, you know, when we're talking about, well, he's got to pivot to other things away from healthcare. Healthcare is more than just healthcare. We need to be investing in the science and the infrastructure of our research pipelines here in the United States.
And I must say, to their credit, even the anti-science Republicans resisted most of Trump's proposed cuts to NIH and other places. So even they understand that there are some cuts that are stupid in the short term and the long term. Whether we can get big increased investments, and you know, those are long-term investments. You know, you invest now and you're going to get a return 10, 15 years down the road. I don't know if any of the politicians have that kind of time frame.
So I think, Grace, I'd add to what you said. I completely agree that good science needs to be funded, right? But I don't believe that the 31 billion or thereabouts of the NIH budget all goes towards good science. I think there's a lot that goes to mediocre or even not good science. And look, there's value in scientific
Sort of like healthcare generally, right?
Right. There's value in training individuals to do science, and yes, that's part of our education commitment. But look, as someone who's raised $30 million of scientific funding, right, I don't think I showed value for that $30 million.
I'd agree, but this is part of a wider thing, Raj, right, which is that we are doing a piss poor job on equity in education as a whole, which is reflecting in piss poor job in sort of equity in senior roles across the board in many, many organizations, but people are talking about it in venture capital and talking about it in corporate boardrooms and all the rest of it, you know, between women and minorities, et cetera, et cetera. We're also, you know, we also do know, and we've got this great example we just had, that science actually does matter, right? And that although the time is decrying it, is that spending on research and technology is coming up. And as I've, you know, lambasted a few times on this program, it's not just in health and biological science, that's a big part of it, but we've got this environmental catastrophe that's ongoing. We've got this renewable energy, you know, idea, which is coming into fruition, coming to mainstream now. Then you can sort of roll in the driverless vehicles and all the rest of it. So sort of add on top of the information technology revolution, which we've had and maybe we've got some benefit out of. Vince will tell us we've got a lot of benefit out of it. Maybe not in healthcare yet, but we're getting out of it. And I think what Grace is saying is that, you know, we've got to think about a new way of training people across the board. And that goes for sort of the academics doing the cutting edge research as well as for everybody else. And we haven't done a great job of it. And by the way, just in the last year and a half, right, well, last year and change now, we've had a collapse in the equity and distribution of education, not so much of the academic sort of higher education levels, but certainly in K through 12 education, certainly for the lower end because of the remote learning and how terrible that's been for people who don't have means to, you know, to manage their children. So I think, you know, there's a bigger point here, and it is terrifying to think that the anti-science groups have got as big and as dominant as they've got. I mean, we have to find a whole new science of reprogramming people who believe in Q, right? Or QAnon. Something we're working on. So I'm with you on that, Grace, and I think that, you know, wish we could do something about it. And yes, of course, Raj, some of that money's wasted, but you know, when you hang out in the world of venture capital, you see a lot of money that gets wasted. Right. Michael?
A small note of optimism. The Agency for Healthcare Research and Quality, which really tries to make the healthcare system better. Some years ago, a Republican congressman's staffer decided that, you know, ARC was redundant and we didn't need that kind of research. And they've been trying to eliminate it in Congress literally for, I don't know, 5 or 6 years. Yeah. And finally, now that they don't control either house, The budget may not zoom up, but at least it's not going to be facing zeroing out every year. And that's one of those, again, like some of the things that are being stuffed into the COVID relief bill. There are small things that are going to help the healthcare system be a little bit better, until one day we reach that point where whether you're black or white, young or old, a person of color, whatever your gender, you'll be screwed over by a disorganized, unfair healthcare system in exactly the same way. That's something that we can all, I think, hope for together.
All right. On that note of optimism, we're going to move on to our next topic. So, Vince, you brought this up in your intro, and I want to say a bit about where this was heading, which was the Julie Yu from Andreessen Horowitz, who may be one of the cleverest people I know in the health tech business. She came up with it. She's basically come up with this concept that we have now, the technology side of building all the things you need to do to be a healthcare delivery system are now ready from the Silicon Valley high-tech end. And this is a bunch of things that, that include, all the connections to telehealth and that kind of stuff, but also involves a whole bunch of things you don't think about, like credentialing services that can be easily done online, payment services, revenue cycle, a bunch of sort of back office stuff that you require to run this. And so she's saying that now, her argument that Vince quoted earlier is that saying that you can now either take these things on easily as a health system that wants to build on new attributes to what you're already doing, or if you're a whole new organization becoming one of these new virtual care organizations, you can build all of this stuff and don't have to build kind of quote unquote irrelevant stuff and deal with irrelevant data scrubbing, which stops you doing your main core business. So Vince, why don't you say a bit more about that? And Raj, we should grab you on this. I think your new company is trying to help somewhere in the midst of all this. So Vince, say a bit more about what you meant and where you think we're going around the sort of the new lava forming.
Well, I think the lava is largely about data, as you correctly reference, and in the data that is about you that is in the medical record has been really hard to get at. People don't want to share. The incentives haven't been there, and the EMR companies, the EHR companies in particular, have been difficult. Epic in particular. You can put that on my tombstone. If they've been very, very difficult to connect with. And so what I see happening is this parallel world of virtual care. People are starting to ask the question: we need healthcare data, but does it have to come from the medical record? You think about the apps that are connected to a patient portal, scheduling and billing. Those could just as easily be connected to your virtual telemedicine portal. What if Amazon were to buy a large telehealth company and they become something akin to the digital front door? Very threatening to the healthcare, should be very threatening to the healthcare incumbents, and clearly is getting a lot of funding from the VCs like Juliet and Andreessen. So I think this will be good for patients. Patients have been very accepting, very positive about the telehealth experience. That's just the tip of the iceberg of what's possible. And as I said earlier, I'd love to hear from some of the other folks, sort of how do you defend against this if you're one of the incumbents?
So Raj, can you dive in here? Because last year you were one of the incumbents trying to figure out what to do this new stuff. Now you're one of these new difficult pushy .com guys. Tell us a bit about what you're doing at Panda and give me a sense about the pieces that will need to be put together to do this stuff.
Well, actually, I probably should have said this in my kind of what's happening this week. I was just sent a link to a new company that was launched today called Truveta, Truveta, saving lives with data, right? So this is our friends from a bunch of health systems, including our friend Rod Hockman from Providence, I think Advocate Aurora, Northwell Health. There's 14 health systems that are going to revolutionize health by providing insights from health data, right? So I'm pretty cynical about this, right? And I think
You may have heard that before somewhere, is what you're saying. There's about 5 other companies that have got 100 million plus lives each and are doing stuff with their data, mostly to help target drugs.
I mean, I think the only good thing about this is when I look at their leadership, one of their positions that they're looking to hire is a chief ethics and compliance officer, right? I'd have hired that person before I announced this, right? To start with. But anyway, they've got 100 million people. They're going to monetize this data by selling it to pharma. Great. I love the approach, Vince, that this is going to create a learning healthcare system and going to lead to better care for the fireman and his 8-year-old daughter when they turn up to the emergency room on a Saturday night. But it ain't, right? This is purely a money play by these health systems. Good on them that they've done it themselves and not thrown this money away to, the big tech players, right? And I think that's one side of it, right? It's there to be done. I really hope it leads to research, virtual clinical trials, real world data, which then leads to better outcomes in the learning healthcare system that IOM has talked about for 15 years, right? But I'm skeptical. On the virtual care piece, Ian and I were talking about this last night, right?
We didn't see you on Clubhouse, so we're not sure it really happened. But go on.
I don't know what, no, I do know what Clubhouse is. So the thing that kind of, I guess I smirked at, but someone got disappointed at when you said, Matthew, in your introduction around, all the pieces are there now to build this. And that's what Julie Yu says. All the pieces have been there for a decade, right? Telehealth is not new, right? It's been there for much longer than that. And okay, we might have some better APIs and we might have fire enabled and that kind of stuff. But really, all of this stuff is not new and it is all ready to go. And right now we have a bunch of these virtual care, telehealth, other companies that, we all know what their valuations are. They're 30x, 35x from revenue to market cap, those kind of things. And when I look at this, and I was actually on a call with someone else earlier today, is when you look at health systems, there are 610 IDNs across this country, right? And the average revenue, net patient revenue of these is about $1 billion, right? The biggest company in this space, in this health tech space, is Teladoc with a revenue of $1.3 billion last year, right? So this is a space that we as health delivery systems own, right? And, that's $1.1 trillion of revenue that's flowing through these 610 IDNs right now. And we're just ceding to whether it's these telehealth companies or whether it's the other new incumbents, whether it's One Medical or Walmart Health or Optum and so forth that are doing this. And right now we need to understand, I'm saying we as health systems, right, that these are our assets, these are our patients, this is our community, and we are trusted here to be able to do this, right? And to kind of be handing this off, I'd say it's the analogy of the arrogant cardiac surgeon saying, yeah, that's not going to change anything. That interventional cardiology, that stent thing, that's not going to change anything, right? And actually, I feel that the health systems are playing a losing game. And so when you mentioned, the company I work with, Panda, right now in a growth and strategy role, I think it's, we need to get together as health systems. And so that's why I brought up Triveta. They've got together 14 health systems to do this. We need to get together as health systems, really own digital health for our patients and not let it be ceded to these other entities, because that's when it's going to be trusted and safe and real. I really worry about these other entities that are coming in. I mean, great for innovation, but I think, Kim, was it you that said that the most misunderstood word in healthcare is patient? I'd actually say the second most understood word is system, right?
Non-system. We have a non-system.
So, but I want to go to Michael. Before that, Raj, just saying, the elevator pitch, 15 seconds. What is Panda doing, and who's it working for in this? So we can figure out what you're up to now.
No, I'd love to. So Panda's a digital health enablement platform for health systems. It's a trusted marketplace where health systems can go and procure and contract with digital health companies. And what Panda does is it's a two-sided marketplace. So health systems come on board and can buy best-in-class digital health solutions. Panda helps them be fit for purpose, works with them so that the rails are in there in terms of people, processes, and technology to figure out what they need in terms of their solutions. And really importantly, to engage in their workflow, right? Optimize the workflow, and then lead to those clinical care outcomes of interest, right? So this isn't just selling more shit to health systems who are then even deeper in shit. And then similarly, so we're narrowing the funnel of those digital health solutions. So we're doing the process of going, this is the category, whether it's wayfinding or patient access or remote care, of defining the category, going through the suppliers, and then coming up with 3 or 4 best in class, doing all of the contracting, the T's and C's. And so what we're doing is we're narrowing the funnel for health systems to choose best in class and making that seamless and frictionless through the integration and onward contract management. But also from the digital health companies, we are narrowing the funnel of health systems that are ready to go and they can sell to. So rather than the 10-3-1 kind of sales cycle, it's going to be more of a 5-3-2. And so the intent is to create this trusted marketplace, which enables both the digital health suppliers and the health systems to win together.
I like it.
So you've put your bet still on the health system side. Just want to help them from the outside. Michael,
well, I think it's on both sides, right? And this is what
I'll rephrase that. You haven't put your bet on somebody coming from the outside and knocking him down. So your technology is helping Sears and Macy's and Barnes and Nobles, not helping Amazon. That may or may not be the result. We'll see. Michael, you've been trying to get him for what?
So I want to build on what Raj said and tease apart a few different threads here. So as you remember, Matthew, at a Health 2.0 a number of years ago, there was this very confident physician about doing virtual visits, and he was in Brooklyn and doing it in Williamsburg for yuppies and talking about how wonderful it was. And I stood up and I said, I have relatives who live in public housing in Williamsburg, which I do. And they're not your Williamsburg, but they're in Williamsburg. And, they've got older and chronic conditions and this, that, and the other thing. Can you do anything for them? And he was taken aback a bit and said no, right? So all virtual care is great if you are healthy. So when we talk about, we can do everything with these new companies coming on, I think you have to distinguish between virtual care and new entrants that see you in person, right? So Walmart and some of those others, the One Medical, they're using technology, but they can still see you as a real person, right? So to think that you can put together something where nobody ever needs to see a doctor or a hospital in person is great for healthy people, and affluent healthy people. Not so great for the people who get sick, who tend to be older and lower educational levels and things like that. Having said that, one thing I wrote about for the BMJ a few years ago is what I called collaborative health. That the system is coming apart in different ways, just like you can, your bank can be fine, but you're still going to use Venmo, right? We're having virtual and in-person coming apart in different ways. We're having the disintermediation. We're having all these different parts, right? So whether or not you're a woman wanting to get pregnant could be whether or not your employer uses somebody like Carrot or whatever for your fertility. And if you're outside that, so we've got all these different pieces in new ways. And that is correct. And I think it's some of what Panda's doing. So we are disintermediating the traditional people to some extent, but we can't get caught up in the hype about the difference between being able to do the back office appointments and when people are sick and they need a human being to see them. Where we are not yet going, in which what I wrote about is true collaboration, is in fact patients at the very center, because the companies that are starting up, while they may be started by people who would put Mother Teresa to shame in terms of their good intentions, also need to get a return on investment. And the person who's paying is not the patient. The person who's paying is the employer or the health system or whomever. And so you may be quote unquote patient-centered, but you're not going to let your customer that's Happy Valley Health System be so patient-centered that the patient goes to unhappy Valley Health System because they get better outcomes and all the rest. So we're in this place where, yes, more virtual, but don't confuse that with everything virtual. And yes, we're empowering patients, but don't confuse that with who's holding the economic power at the moment. And maybe, just maybe, we'll turn to something where it is truly patient-centric and it is truly collaborative, but we're a ways from there.
I mean, let me tell you where the young doctor from Brooklyn ended up, right? So I don't know if you know.
I know, yeah.
Jay Bonstein, he's ended up, he created his own company called Sherpa, which was basically was purely online and was doing all stuff. And that got integrated into Crossover, which Crossover started out as offline, but needed an online component, but it's kind of a new sexy thing. And Crossover is now going to be the rolling out with Amazon to do centers, to basically do health centers for Amazon workers, not like the fancy guys in Seattle with the high salaries. These are the people that did making $15 an hour in the warehouses, and they are saying that there's a decent amount of, now they're not yet going for the Medicare Advantage crowd, but or for the dual eligibles, but nonetheless there's
that's great.
definitely a balance between offline and online there.
The Amazon people will still have access to a real physician if they need it, correct?
Yeah, and I mean, and one of the things we started is that the organization, which is called the the Virtual Impact. Sorry, I've just been joined about 15 dogs in the room. It's called the virtual the Impact Societies, impact.timesociety.org. They're really talking about doing online only, basically, clinics for things like diabetes and GI and the rest of it. Anyway, Raj and Grace, you're both complaining about what's been happening, so jump in.
All right, I'm going to complain first. And I really am getting the sense that I'm not really optimistic in these episodes. However, I want to comment about where everyone goes wrong. This whole revolutionizing health. Not everyone is born healthy and is healthy. So when you're revolutionizing health, you only are taking this part of the spectrum of conditions because it's proactive wellness seekers or healthy, people who have acute situations, people that cross the prime meridian into now chronic illness. Then we're moving over into life-altering, life-limiting, like cancer, ALS. And then we're talking active death, terminal illness, which no one is innovating about, but which we're all going to do. So that's first of all the problem. And then there's this whole concept of virtual care transforming. Not everyone, because of the spectrum that I described, will just solely use virtual care. And that's okay. The virtual care and the telehealth and that component is a necessary tool for these people to have continuity of care. And I feel like that's not emphasized enough. And it's also a tool for the primary care partners who are trying to juggle all of the fragmentation and administrative burden and work that needs to be done. That's why we have that telehealth, digital, virtual care component necessary. So I guess that's my vent here about why we're missing the boat when we're only talking about health. You're ostracizing and leaving out the millions and millions of people that don't fit that health equation.
So let me jump in to a couple of things that Grace said. First of all, slightly sly, but when you say that we're not doing enough about kind of death and dying in that process, absolutely agree. And my approach to that is when all of these billionaires that have made money out of Silicon Valley and healthcare and whatever, they start dying, then suddenly there'll be apps and technologies because I'll be like, oh shit, now I actually care about it, right? Okay.
They're moving to Mars.
Oh yeah, well, that's the other piece. And then the second piece, and this could be a very long topic, but I'm still so confused by, even some of my friends, when they are pitching to VCs or other systems about, we are democratizing healthcare, right? And I just don't know what that means. And maybe I'm being blunt here, but we do need to improve access to healthcare, but democratizing healthcare doesn't make sense to me. And then the second piece is really around delighting patients. Like, how do you delight a patient when they're being told about their mammogram and their breast cancer diagnosis? I mean, again, this is not about going into a coffee shop, right? You know, and I remember having a panel session about 10 years ago about, Atul Gawande wrote an article about the Cheesecake Factory and how it ran so well. And I had a couple of people up on stage, and we did this panel session. Someone said, well, that's all great, but going to a Cheesecake Factory isn't the same as going to a hospital, right? I go there because I want to go out and have a nice meal and whatever. I don't want to go to hospital ever, right? So it's about tolerating that process. So that's those are two things that are kind of bugbears of mine as well.
Matthew, could I just jump in at the end of this very quickly? I mean, I think what I'm hearing from this conversation is that there's almost like four possible scenarios. There's these disruptors will do their business and make money for themselves, but maybe weaken the incumbent somewhere. I'm not a huge fan of that one. I think I'm a big fan of what Raj is talking about, which is sort of learn and deploy these better solutions inside the existing health system. I think that's what Jeff Goldsmith's piece a couple of weeks ago was about. I worry a lot about the third option, which is kind of pimp my ride, which we just add all this, you know, clutter onto what is already a dysfunctional system. And that to me, a lot of that is going on. And where the real promise is, I think is, and that's why the crossover example you talked about is kind of Bob Margolis 2.0, you know, sort of building end-to-end patient digital, but with digital support at the front end, but recognize all of you are saying people are going to get really sick and they need UCSF, they need Stanford, they need those institutions. And we've got to be really careful we don't weaken them in this process, as evidenced by COVID. Jeff and I are working on a piece about scale and how scale proved to be valuable in COVID. And I got to tell you, just getting feedback from the CEOs, you know, we'd have been completely buggered in this country if it were not for the top 100 IDNs and what they've done over the last 12 months. That's a technical term, by the way, that we hookers use.
Buggered is a rugby term, I believe.
It is.
All right, Kim, and then we're going to wrap.
A couple of quick comments. So to Vince's analogy, if you're in the middle of the ocean and the lava's boiling up, you're going to die, you know, and everyone around you is going to die. So that's an interesting analogy. So, you know, I'm all for these new entrants, and you know, Michael mentioned Walmart. I think that's great. The trouble is we don't have enough people to do the care. You can't train doctors, much less NPs or physicians, in a timely way that we want to, and then the medicine doesn't really want to. To scale the care, you're going to need to go not just virtual, but you're going to need to go AI. And an argument I've been making over the years is we keep looking at the wrong competitors. The people we need to be looking at is what China is doing, because China's already doing, you know, WeDoc, and you know, TikTok is an AI firm. If we're not careful, you know, we're gonna see a bunch of people come into our country and do virtual care, not within our regulatory system, and we're not gonna be able to stop it. And it's going to be a very interesting battle, because it's going to be.
It's already happening, Kim. It's already happening.
Already happening. That's right.
All right. Okay. So we're at the end of the show, and as traditional, we'll go around quickly and ask people what they're expecting to come next week, what they're looking at. So I will start with you, Vince.
You know, this has really been a good discussion. I maintain my optimism that I think the changes that I'm seeing are, you know, we truly are getting to constructive healthcare reform. I've been watching the system and participating for 30 years, and the incumbents have been so resistant. You know, I'll quote Kim, who wrote recently, you know, the hospital is like the department store, you know, trying to be all things to all people. I think back to a strategic planning exercise that I went through with a hospital board. This was over 20 years ago, and we developed scenarios for the future. One of the scenarios was the hospital back to the future, that delivery systems become hospitals instead of trying to be all things to all people. The board pretty much categorically rejected that. It wasn't within the DNA of what the institution was thinking about, but I think we ought to revisit that scenario. Just again, to end on an optimistic note, I think, you know, there's so much going on right now. I think it will shake up the incumbents, and hopefully healthcare will become more of a system. Certainly, as Grace has adequately or more than adequately pointed out, it's not very patient oriented today.
Michael, your next couple of weeks that you're looking at.
Well, it was a great discussion. I can't say it left me super optimistic, but it was a great discussion.
Understood.
You know, in the long run, we're all going to be optimistic. I would say that we're going to have in the next few weeks, we're going to have improvements in healthcare for the least powerful members of our society due to the kind of amendments, whatever they are, however many they stick, will be some that come through with the COVID relief bill. So that's good. At the same time, we're going to continue to see transformation, revolution, and paradigm shifting happening every other day with various Silicon Valley companies as they're bought up. And we shall see how that develops, whether that ends up with greater systemness or not. I thought Ian, you should do the scenario thing for a living. That was pretty good. See which one of those scenarios comes about.
All right, Grace.
I guess I'm hoping to see if in the short term, we're going to have any major announcements that we're going to boost vaccine supplies. How can we boost manufacturing? How can we make some kind of deals? I don't know whose hands are shaking behind the scenes, but we need to make vaccines more widely available so that we can supply the need that we have here and across the globe.
Well said. Kim.
So my wife is scheduled to get her first vaccine Saturday. I'm scheduled on Monday. Knock whatever, all goes well. She had to jump through a ridiculous number of hoops to get those. And now I'm worried about what kind of hoops they're going to have to do to get the second vaccine. And it should not be like this in America.
Raj.
So I'm really positive about the numbers for COVID-19 cases, patients in hospital, number of deaths. I mean, they are plummeting right now, and it feels like this drop is real. We need to wait and see what happens after all those people got together in Tampa last weekend. But I'm really feeling good about us. It's still 2,500 to 2,600 deaths a day, right? That's a lot. And maybe part of this thought is we're getting immune to that because it was up to almost 4,000, right? But it's really coming down. So I'm looking to see how that continues to come down, hopefully.
Ian.
Well, I'm there. That's where I started on the vaccine thing. I know Slavitt reasonably well, and I think he's working 24/7. He's under promising and hopefully over delivering. And I back Andy. I think J&J got approved in pretty short order, and I think that will boost supply. But it is still ridiculous the hoops individual patients have to go through to get access to it. And I think the White House is acutely aware of that and is trying to do everything. The metaphor I've been using with people is Dunkirk. This is about trying to use big ships and little ships to get as many people to safety as fast as possible. And I think Grace's point at the beginning about people like cancer survivors or people with cancer, it's ridiculous that we're not, getting them to the front of the line. So let's get more ships out there and let's get it done.
Yeah, I think anytime you put three Brits together on a show like this, you're going to end up with the Dunkirk metaphor. All right, so that's been the THCB gang for today. I want to thank my panelists, Ian Morrison from Menlo Park, California, Raj Aggarwal from Philadelphia, Kim Bellard from the Midwest in Cincinnati, Michael Millenson also from the Midwest in Cincinnati, in Chicago, Grace Cordovano all the way from New York, New Jersey, and Vince Kuraitis from the wilds of Idaho. I just end this one saying that I was actually in we'll know this because we were at the Institute for the Future together. Institute for the Future had an online session just the last day or so where they were looking at scenarios for climate change and how to be sustainable. And there was kind of an argument that you could do a technology scenario that may save us, but technology probably wasn't going to be enough. But we need to get used to massive transformation, and it's everyone's role and everyone's job. And I think that's also true with the healthcare system. So let's hope that will pan out in the next little bit. We will be back to discuss more of this. There'll be another THCB gang this time next week, February the 18th, 2021, another gang. Look forward, same time, same place. Look forward.